I'm going to introduce Ryan Brodman. He's going to talk to you about medications that are disease-specific to what was spoken about earlier.
So we'll start off with some pharmaceutical treatments for diabetes. And first we'll just go over a few of the oral medication drug classes. So to start off, we have the biguanide class. And that really only includes one medication, metformin, which is really still the gold standard for all diabetes patients, type 2 diabetes patients. Metformin works in a variety of ways. First, it helps to decrease any liver glucose production. It decreases any absorption of glucose from the intestines that you might take in through meals. And then it also improves insulin sensitivity. So what we see in type 2 diabetic patients is that not only is there some decreased production of insulin from their pancreas, but there's a huge insulin resistance component where their peripheral tissues, such as their muscles, just aren't really taking up the glucose that might be in their blood. So they're not utilizing the glucose as well as patients that don't have diabetes. So metformin improves the insulin uptake into peripheral tissues and the utilization by those tissues. And all those things contribute to decreasing serum blood glucose. When we talk about the best dosage of metformin, we really like to titrate patients up to 2,000 milligrams per day. The maximum doses that you might see in some clinical resources is 2,550 milligrams a day. But really, when you look at the different studies and medical literature, there doesn't seem to be much benefit to going above that 2,000 milligram dose for the majority of patients. Next up, we have sulfonylureas. And this class, we have several different medications. We have a couple up here, glipizide, glyburide, and glimepiride. They really work to increase insulin release from the pancreas. So they're only going to really work in those type 2 diabetics that are still producing insulin from the pancreas. In many patients, they can get to a point where their pancreas has essentially shut down and is no longer producing insulin. So, sulfonylureas would not actually be effective in that kind of population. In terms of which medication in this class to choose, really we tend to stay away from glyburide more so nowadays because it's longer acting and can lead to more hypoglycemia in patients. Glipizide and glimepiride tend to be shorter acting, definitely tend to accumulate less in patients that have renal impairment, and we do tend to see a little less hypoglycemia than glyburide. So those classes of medications have been on the market for a while. Some of the newer classes that we've seen on the market are the DPP-IV Inhibitors, which stands for dipeptidyl peptidase 4 enzyme inhibitors. And essentially what these medications do is they increase hormones in our body called incretins. And these incretins work to increase insulin synthesis and release from the pancreas. They also decrease glucagon secretion from the pancreatic alpha cells. And normally these incretins are released throughout the day, but they're particularly released in large amounts after meals. So what we see with the DPP-IV inhibitors like Januvia, they mainly affect postprandial blood glucose levels more so than fasting blood glucose levels. And Januvia is the most utilized and most commonly seen DPP-IV inhibitor amongst our diabetic population. Next up, we have thiazolidine diones, and these really work through increasing peripheral utilization and insulin sensitivity among peripheral tissues, and so just increasing the uptake of glucose by our muscles and various tissues. Now, these also do increase fluid retention and sodium retention. So, Actos, Avandia, you've probably heard different news reports over the past several years about potentially, using caution amongst heart failure patients, since they could worsen those patients' conditions. I did want to spend a little bit more time just on metformin. When you look at all the guidelines, it still is the gold standard, still first-line standard of care. It's very inexpensive. It's on all insurers' formularies. Be a tier 1 preferred generic. It can be continued when patients do need to use insulin. We do see it stopped quite often, but really, unless the patients have some intolerances or contraindications, there's really no reason to stop metformin because it still works even if the patient is insulin dependent. And it is commonly discontinued because of intolerance. So I wanted to talk to you about a few ways just to overcome some intolerance. Really, the main side effect that we see for the majority of patients is GI upset and diarrhea. And what patients might not always know is that these side effects, you tend to grow tolerance to them. So you want to, as a clinician, as a provider, make sure that you discuss with the patient that, hey, these are some side effects to expect, and you, like many patients, will grow tolerant to them after a couple weeks, maybe 2 to 4 weeks. So don't give up on them at the first sign of diarrhea. If you want to try to overcome those side effects, one thing that you can do is titrate the dose in a slow fashion. So you can start patients off on metformin immediate release 500 milligrams a day or even 250 milligrams a day, and then every 1 to 2 weeks increase their dose by 250 to 500 milligrams. So it might take you a few weeks to a few months to get them to that target dose of 2,000 milligrams a day, but it's worth it if you can make sure that that patient's going to tolerate their medication. In terms of medication, ways to help them better tolerate metformin, there's some other things that you can do. You can have them take it with a meal, either right before or right after. You can have them switch from the immediate release formulation to the extended release formulation. The extended release formulations are a little bit better tolerated. And while they're directed in their package labeling to be taken once a day, if members experience diarrhea or GI upset on the extended release formulations, taking them once a day, they can actually switch to twice a day dosing. And that's not going to impact the medication's efficacy or safety. The one thing I did want to say, you may have seen Fortimet or Glemmetza in some of your patients, or maybe in the news. And these are medications that are formulation, they're extended release formulations of metformin, but I would really advise against using either of those products, either the brand or the generic. Both of them are generically available, but the generics for a 90-day supply of the maximum dose are about $12,000. So if you annualize that, we're looking at $48,000, $50,000 a year, which would by far be the most expensive diabetes medications you could use. So there's really no great value for these products, and if members can't tolerate other formulations of metformin, then I would just suggest moving on to some of the other diabetic classes, some of the other anti-diabetic medications that really are going to provide more value at a much more reasonable cost. So I wanted to talk about a few of the newer classes of anti-diabetic agents and just kind of give you a little background on what they're doing in the body. So the diagram on the right, if you kind of work from the bottom up, you can see that the DPP-IV inhibitors, they block that enzyme, the DPP-4 enzyme, and this leads to less inactivation of the incretin hormones, such as the GLP-1 hormone. And by increasing the incretin hormones, not only do you stimulate insulin release, but you also inhibit glucagon release, and thus you lower blood sugar. So these agents generally lower hemoglobin A1C 0.5 to 1%, and they primarily will reduce postprandial blood glucose levels. Some things to think about in terms of advantages. They are weight neutral, so in terms of diabetic patients that are overweight, these shouldn't negatively impact their weight, and they have a low minor risk of hypoglycemia compared to drugs like the sulfonylureas. So overall, these medications definitely have a good efficacy and safety profile that really make them a good class of drugs to go to. Disadvantages, one big one is the renal dosing. All of them except linagliptin, which is Tradjenta, have to be renally dose adjusted if members have renal impairment. However, there are dosing guidelines for any patient with renal impairment for the other medications, such as Januvia. So really, there's not a big advantage to use Tradjenta, even in the renal impairment patients, unless that's their preferred product on their insurer's formulary. But most insurers are preferring Januvia nowadays. The next class up that we haven't talked about yet are the GLP-1 agonists. And these include medications like Byetta and Victoza, Trulicity, and Tanzium. And so on the last slide for the DPP-IV inhibitors, we talked about how DPP-IV inhibitors increase incretin hormones, such as GLP-1. So these GLP-1 agonists are really acting like synthetic incretin hormones. And so the effects that you're seeing on the screen are really similar to the DPP-IV inhibitors. However, these medications do tend to decrease hemoglobin A1C and blood sugars to a greater extent than DPP-IV inhibitors. So we're seeing these used much more frequently over the past several years. They do primarily affect postprandial blood glucose levels. And the big advantage that providers and patients like about these medications are that they cause a significant amount of weight loss. And actually, there's a product that's the same active ingredient as Victoza called Saxenda, and it's exclusively used for weight loss, and it's used just in patients for weight loss, and they don't necessarily have to have diabetes. Another advantage is that several of these medications are once weekly formulations, so for patients that have issues with adherence, Byetta was formulated into a once weekly formulation known as Bydureon. Trulicity is also another once weekly formulation, as I believe Tanzium is as well. Although, really when we look at the data, even though Victoza is once a day, it's still the most commonly utilized medication in this class, just because of its efficacy, and it does, when you look at the data, seem to have a little bit better advantage in terms of weight loss. The newest class of anti-diabetic agents that we have on the market are the sodium glucose cotransporter 2 inhibitors. And you can kind of read through some of the details on the slide, but really what they do is they increase the urinary excretion of glucose. So these medications can actually be used like metformin in patients that are insulin dependent. God bless you. So even when the patients are on basal and mealtime insulin, this is a medication, because of its mechanism of action, these medications can be continued in those patients. And we've actually seen type 1 diabetics use these medications as well. So while the evidence isn't very robust for the use in type 1 diabetics, there continues to be studies, in terms of the impact of these medications, type 1 diabetics. And I wouldn't be surprised seeing down the road if they had a supplemental FDA-approved indication for use in type 1. So here are some of the advantages and disadvantages. They do work on fasting and postprandial blood glucose. They do lead to some significant weight loss, although not to as great of an extent as a GLP-1 agonist. In terms of side effects, the one I would bring to your attention is the genital infections, mycotic infections, yeast infections that many patients do experience. So that's something that just, good for patients, providers to be aware of, and that they might have to treat those infections down the road if they arise. In terms of insulins, they really are the gold standard for patients that just aren't able to get controlled on oral agents, especially those patients with significantly high A1Cs. Usually you're going to see somebody started off on a long-acting insulin like Lantus first, and as they titrate the dose and get the Lantus up to more of a maximum dose, they might move over to mealtime insulin if the Lantus or the basal insulin really isn't doing the job. In terms of selecting an agent, really with the long-acting insulins, we see Lantus most commonly utilized. There was a new medication that came out in the market in the past year called Basaglar, and it is essentially, it's not a generic, it's a brand competitor to Lantus, and it's the exact same active ingredient and the exact same strength. So there's really no difference between Lantus and Basaglar. It's just it's putting more competition out on the market. So you're going to see some insurers prefer Basaglar and some insurers prefer Lantus, just because efficacy and safety are the same. So they're going to make a decision based off of cost and who they're able to get the best contract with. Toujeo is also a new insulin, basal insulin that we've seen in the past couple of years. Exact same active ingredient as Lantus and Basaglar. It's just a higher strength. It's got 300 units per ml versus Lantus and Basaglar, which have 100 units per ml. And so it's not necessarily something you want to go to for most patients. It still has to be dosed once a day, even though it lasts a few hours longer than Lantus. And actually, patients tend to be on higher doses of Toujeo, higher unit dosages of Toujeo than Lantus. So in terms of advantages, really Toujeo is more for patients that have to be on extremely high doses of insulin per day. So think of somebody that total between mealtime and basal insulin, they have to be on maybe like 200 units of insulin a day. So those patients, they want to decrease their volume of insulin that they're injecting into their body, so that they're not having absorption issues with the high doses of insulin. So I also wanted to talk about a few other classes of medications that don't specifically target patients' blood glucose, but that you're going to commonly see in patients that are diabetic. When you look at the guidelines now, the American College of Cardiology and the American Heart Association, they have highly recommended in their most recent guidelines statins in diabetes patients, particularly really any diabetic patient between 40 and 75 should be on a statin, and either a moderate intensity statin or a high intensity statin. You can see the various levels of statin dosages and which category they fall into on the screen. If patients have a cardiovascular risk of 7.5% or higher, those are the diabetic patients that you're going to see on the high intensity statins like atorvastatin, which is generic Lipitor, or rosuvastatin, which is generic Crestor. And if their risk is less than 7.5%, then you're going to probably see them on a moderate intensity statin. The one thing I would say about these medications, and I should say the ADA's guideline still is LDL of less than 100, so that's going to impact which medication you would select for your patient. But I would say if you look at the bottom of the second column, there's a medication called pitavastatin. That's the active ingredient name of Livalo. Livalo is the only brand statin that's left on the market. Everything else has gone generic, including Crestor. Crestor went generic last May, and it's a multi-source generic now, several manufacturers, so the price has bottomed out. There's really no advantage for Livalo over any of the other statins. So in terms of efficacy and safety, we're really not seeing unique value to Livalo. So what I would suggest is that you really save that patient that medication for last line use in your patients, and you try to exhaust all the other statins before going to Livalo. In terms of some of the complications of diabetes, we do see a significant amount of neuropathy in our patients, and these are a couple different classes of medications that you can use. When we look at, what does the data say? There's few head-to-head trials. There's really no evidence of superiority between one medication versus another in terms of treating neuropathy. And so it's really just going to depend on the individual, because there's a lot of inter-individual variation in terms of how patients respond to these medications. Gabapentin, generic Depakote, generic Effexor, generic Cymbalta, those are all various medications that are utilized. You will see some opioids, more second-line use, not gonna be first-line use. Lyrica is the most studied medication, but again, it's not proven to be more effective than any of the other options. And I tend to, kind of use Lyrica after I've tried some of the generic options, since Lyrica is still brand much more expensive than any of the other options. And lastly, for diabetes, I want to just give you a couple slides of just a few medications that can increase blood sugar, as well as decrease blood sugar or potentially mask blood sugar, low blood sugar. So you see here are a couple classes of medications. Protease inhibitors for one, we're not really sure if it's the drugs themselves or it's more so a metabolic defect, in HIV patients that's just kind of exacerbated by these drugs that increases blood sugar. But regardless, majority of patients are going to have increased blood sugar when they're on those medications. I didn't add this to the slide, but thiazide diuretics, because they tend to decrease potassium in the body, and potassium levels kind of mirror insulin levels. So when you decrease potassium, you tend to see decreases in insulin secretion, and so that actually will lead to hyperglycemia as well. Here's a few medications that can cause hypoglycemia. For the sake of time, I'll just kind of breeze through that. And I did want to talk about some medications that can mask hypoglycemia, particularly beta blockers. And beta blockers, what they do is you normally have several symptoms with hypoglycemia, such as decreased heart rate and potentially, shaking your hands or tremors. Well, the beta blockers will, remove those symptoms potentially, so, that could, remove the warning signs to a patient that they're going through a hypoglycemic attack. However, it's important to note that beta blockers don't decrease all the symptoms. So these patients, if they normally had dizziness or sweating with a hypoglycemic attack, they would still have those symptoms. So it's something, if members are still on something like metoprolol, something like a atenolol, you just want to kind of let them know that those are the things to be aware of if they have a hypoglycemic attack, that they're not going to see decreased heart rate or tremors, but they will still see dizziness and sweating. And then those, interesting enough, can also actually worsen asthma, particularly the non-selective beta blockers like propranolol, because there's beta-2 receptors in the airways, and by blocking those receptors, they actually can narrow airways in asthma patients. So something to just kind of be aware of. And in those patients, we tend to stick to more beta-1 selective beta blockers such as metoprolol. However, you have to kind of be, even with the beta-1 selective beta blockers, you have to be aware of the dosing, because at significantly high doses, they can still worsen patients' asthma as well.